All right, we're ready. Well, welcome to the folks that came out on this frigid night. Um, Eric and I had this idea that we got together about we wanted to help people with movement longevity to do what it takes to move better, move longer. One of the biggest things we see in therapy is people come here and they say, my knee or my hip started hurting me 2 years ago, and then I went from where now I can hardly walk at all, and they just went downhill so quickly, and then now they're finally doing something about it, and it's a big uphill battle from there, and some people choose not to continue that battle like they should. So we're trying to come up with some things and some ways to help people um, take action on this. I'm going to have Eric come up first and talk just a little bit about some of the stuff that he's done with Emory University with movement, with some of the students there, and some pretty cool stuff, and some other just tidbits of information. And then we're very thrilled to have Dr. Yarbrough here tonight. He's going to talk about hip and knee and good kind of cool stuff here. And I hope I didn't break that. And so we have some question and answer afterwards. So it should be a good night. And there's food back there. This will also be on YouTube, so you can hopefully you guys will be beacons of hope for some of your neighbors and friends. And you can, when they hear complaints about their knees, say, hey, you got to go see Doc. Let's get the ball rolling here. So Eric, come on up here. I'm going to mic you up. There we go. They're going to be good for you. There we go.
All right.
Introduce yourself.
Yeah, thank you, Matt. It's nice to meet all of you. My name's Eric Holzhauser, and I started here at Champion as an intern in 2019, and then came back full-time in 2022. And one of the things that I'm really passionate about is getting people healthy and keeping them healthy. So like I do some work at Emory University with the business school students there. I do a leadership and well-being program. And kind of the idea is to get them in a healthy lifestyles early on. So then when they're, as they progress through their careers, they're not coming in with all sorts of aches and pains, or at least not as much. And I think one of the really cool things that the science is showing is like how much we can prevent a lot of these issues. And one thing that is one of my pet peeves from physical therapy school is we get up and talk about how bad it is to just sit there and be sedentary, and while everyone's sitting and being sedentary. So let's get everyone up. we're gonna move around a little bit. Partially because Dr. Yarbrough has some really awesome information for us tonight. And the science shows if you move around a little bit, you'll actually remember about 5% more, which is kind of cool. All right. So any aches and pains right now? Anything we gotta watch out for? We'll keep it pretty easy. So let's just start just kind of moving the ankles a little bit. You can shift weight onto one side, so you can go one way then the other, then shift back the other way. There you go. Do a few ankle circles. Go ahead and grab the chair in front of you. We're going to do some mini squats here. So just go up and down. Yeah. You guys are doing therapy. If anything doesn't feel comfortable, don't do it. You can always just do a little baby one here. And another thing you can try to help activate your hip muscles a little bit is if you put your hands on the outside of your thighs and then press into your thighs like that, or into your hands, and then just kind of go up and down. You'll probably feel it in your rear end quite a bit. Wake up some of those muscles. All right, then hold on to the front of the chair. Let's do a little bit of reaching. You can always, if you have bad shoulders, you can just kind of twist your body a little bit, reaching back and forth. There you go. All right, I think you guys are better than the MBA students. Like when I do this stuff when they're moaning and groaning, it's like they haven't moved in 10 years. Right? Yeah.
There you go.
Yeah. All right, maybe do a few reaches behind you. Yep, and then you can kind of cross your arms, reach in there. All right. we're doing more hips and knees, so we don't have to worry about the upper body too much. Maybe we'll do a little arm circles, do some chicken wings there, pinch the shoulder blades back together. All right, how you guys feel?
Good.
A little looser
learn.
and everything.
Woo!
Ready to learn? Yeah, and I'll let Dr. Yarbrough cover a lot of this stuff, but really the things that you need to look at with joint health is, movement is a big piece of it. So um, not only the right type of movement, but the right amount of movement. Yeah, you guys can sit down if you want. I didn't tell you. This is like Simon Says. So movement is really awesome. Not too much, not too little. You got to kind of find that sweet spot for everyone. Eating the right foods is really important as well. Getting sleep. Basically all the stuff your mom told you to do growing up is good for your joints. That we didn't do or didn't do, and now we're trying to figure out how to do it right. And then, some of the stuff that we're working on here at Champion is developing programs to help you move efficiently. Like we all know, like the physical therapy and the rehab side, you hurt your knee. All right, we got to get that knee stronger. We got to get that knee moving. But then once you get out of therapy, what are the type of things we need to do to move well and move effectively so you don't end up back in here again? And one of the things that I find is really cool is learning from babies how babies move. So that's one thing like we've been learned a lot about in school, and there's actually nothing that says that we can't move really, really well into our extended years. The problem is we stop doing the stuff that we do as kids. So as kids, you see people that are rolling around, they're crawling, they're developing all of that core stability, all that hip mobility, knee mobility, shoulder girdle strength. And then we go and sit in a chair for 40 years. And then it's no wonder that we can't move. But one of the cool things is if you actually start doing some of those basic movements, what we see is if you start rolling again, maybe doing a little bit of crawling, doing movements where you're just kind of transitioning into kneeling here. And you got to start slow. But if you do that regularly, all of a sudden you can get down and do a deep squat or do something like this that maybe you never thought you would be able to do. So with that's kind of a little taste to warm you guys up for Dr. Yarbrough. So I'll go ahead and introduce him, and we're lucky
guys,
to have
thank
him
you. That was great, man. That was great. That was great. Don't make me do any more stretches. I might fall over.
Okay.
But anyway, I just want to thank Matt for this opportunity to have a few minutes to share some knowledge and get to meet some new folks and see some patients as well. I'm Dr. Yarbrough. I'm a board certified orthopedic surgeon, and I specialize in hip and knee surgery. And little just briefly about me, I grew up in Columbus, Georgia. I started out doing general orthopedics. I went to Emory for med school, did my residency in Charleston, South Carolina, practiced general orthopedics for almost 10 years. And then I moved here in 2012 and followed in the footsteps of another surgeon, Dr. Caval, and kind of started specializing in hip and knee replacement back around about then, really about 2009, 2010. And I really enjoy what I do. And even though I'm an orthopedic surgeon, honestly, less than 5% of my patients end up in the operating room. Statistically, I mean, I treat far more patients non-surgically than I do surgically. I love to operate. All surgeons love to operate because we grew up playing around in the shop and fixing things, and it's very gratifying. Majority of patients do very well. But enough about me. You're here to learn about hip and knee health and hip and knee injuries. And I thought what I would do is really kind of give you guys a lot of opportunity to ask questions and speak. And before we go into that, I did want to hit on maybe 3 myths in the orthopedic world. And people always come to me and they have these preconceived notions about arthritis, about running, about joint replacement. And 3 things that kind of popped into my head were number one, that running is bad for your joints, that running puts a ton of pressure on your joints, and that, it causes arthritis. And believe it or not, arthritis has never been associated with runners, long distance runners, marathon runners, and athletes do not develop arthritis any more than the rest of the normal population. As a matter of fact, some studies have shown that running is protective for your joints. And when you think about it, it kind of makes sense, because people that run are typically in a little bit better shape and take a little bit better care of themselves, perhaps. But even walking on concrete, running is not, a bad thing for your joints. And so people ask me that question all the time. Even if you have arthritis, if you have a little bit or even more than a little bit of arthritis, getting out and running is not doing more damage. And I get that question probably almost every day. The second thing I want to talk about is the onset of arthritis symptoms, whether it's your shoulder, whether it's your a hip or a knee. People come to me and they say, Doc, I just, all of a sudden I was out in the yard this weekend and I was raking leaves, picking up sticks, and this pain just came out of nowhere and I couldn't move my knee. It came on like a lightning bolt. And they come see me, we do an exam, we do x-rays, we get an MRI if sometimes. And oftentimes the culprit is osteoarthritis. And they look at me and say, it came on all of a sudden. It can't be arthritis. Well, that is the biggest myth out there, is that arthritis symptoms don't come on suddenly. Everybody has the old, tale that arthritis is a slow, gradual onset. And for some people, that's true. But probably more than half of patients that experience the symptoms of arthritis, the symptoms come on suddenly. And so that's just one thing I wanted to put out there. And then the last thing is talking about surgery, metal and plastic. And, if you are in a position where you're miserable from your arthritis, you've failed your treatments, injections, medications, and your quality of life is such that you're limiting your activities, you're having trouble sleeping, that's when it's time to talk about joint replacement. Okay. And the reason is joint replacement is not perfect. It's not the holy grail. It's wonderful, but it has drawbacks. Number one, I tell everyone the same thing. If they're thinking about having a knee replacement, or a hip replacement for that matter, this is wonderful, but it's not perfect. As you can see, it's metal and plastic. Your God-given knee has no metal and plastic in it. Okay, if you think this is going to feel just like your knee felt when you were, 16 or 18 years old, unfortunately, you're probably going to be sadly mistaken. However, when your pain is horrible and it's limiting you, most patients are very happy and satisfied with the pain relief they get from the replacement. Okay, but it might click. It's metal and plastic. People come to me post-operatively and, Doc, something's wrong. I can hear it. It clicks. Well, I have to remind them that is normal. And acutely after surgery, people do typically have a little more clicking, and I think that's related to the swelling. And then this also wears out. Over time, this implant wears out. And people always ask me, well, Doc, can't you just go in and replace the plastic insert? And that's what this is. This is the plastic insert. We can. However, there is a problem. And did anybody walk here today? Did everybody come in a car? Okay, so this is similar to the transmission in your car. There are no gears in this knee replacement. There are no gears in this hip replacement, but there are bearing surfaces. And those bearing surfaces rub together, and through friction, they create third body particles. And in your vehicle, when you have a worn out transmission, the gears slip. Okay, with a hip or knee replacement, that third body particle wear incites a process called osteolysis. And osteolysis, osteo is bone, lysis is absorption. Osteolysis is a process whereby those particles cause damage to the surrounding bone and soft tissues, and that is the downfall of joint replacement. Now, luckily, we've gotten really good, and most of these joint replacements will last 15 and even 20 years and sometimes longer. But we can't typically go in and just replace that bearing surface because of that process. That osteolysis typically causes loosening of this implant around the bone. So I'm not much on long speeches, so I'm going to end there. And but anyway, what questions does anyone have? I'm happy to answer any questions. 15, the best data is 15, and we're working on 20-year data, and there's some promising data. Yeah, so great question. There are multiple factors that will influence that. Age, so believe it or not, younger age is a risk factor, obviously, because you're more active. I mean, that's relative. I'm gonna. I mean, yeah. So fifth in your 50s, and then body weight, larger body weight puts more stress on the joint. And then also it depends on how well we put it in. Okay, the alignment of the implant, and if you get your implant in aligned properly, it's going to last a lot longer. Also, correct, the technique. It is the technique. So how well you cement your knee in, or how well you some people use cementless knees, and so some of it is down to surgical technique. Absolutely, 100%. Good question. So you mentioned that sometimes they wear out. Yes. Yeah. What do you do then? That's a great question. So, like I said, sometimes we can go in and just change out that insert. That's a minority of the time. I would say honestly, less than 15 or 20% of the time can we just go in. So we do, yeah. So what happens is with osteolysis, believe it or not, these implants, that you get a little separation between the implant and the bone. And so what happens then is it gets a little bit of micro motion in it. And so normally when we do a revision surgery for a hip or a knee, we remove this implant, okay? And then we have to replace that. You're going to have some damage to the bone, so we put in a new implant. But that implant is going to have more metal and typically more of a stem that'll go up into the femur and down into the tibia. And people, revision surgeries come a long way. And a lot of those patients do very well, but it can be a bigger surgery, a bigger recovery. Believe it or not, sometimes fortunately, some people after revision knee replacement surgery actually recover quicker and easier than they did from their primary, because you're treating a different disease. They don't have an arthritic stiff knee when they come to see you. Typically their flexibility is better, their range of motion is good, they just have a worn out part. So but it varies. You're dealing with more unknowns when you do that type of surgery because of the bone quality issues, because of potential damage and to ligaments and bones and whatnot. So it's just a little bit more of an unknown. But good question. Thank you. Yes, ma'am. Okay. When you go in and you have any replacement, what is really the recovery time? Great question. Great question. And you're not going to like my answer. So everybody has that friend or that cousin. I mean, I have those patients that come back in 2 or 3 weeks and they're golfing and they're running around like, nothing like they had a haircut. That's my favorite thing. It's like they had a haircut, and that is not most patients. And it's really, human nature is to compare ourselves to others, and that's normal. But when you start comparing your recovery to that guy, you're going to be sadly disappointed because, on average, what I quote my patients for a knee replacement, it's different from our hip. For a knee replacement, on average, most patients by around week 5 postoperatively, which is about a month, are probably about 75% back to normal. And even that's not, and then some people take longer. I would say a fraction of patients hit that milestone at 3 weeks. Some people don't hit it for 8 weeks, and then a smaller percentage may not hit it for even longer. So when you say recovery, yeah, what does that mean really? Does that mean you're back to doing everything you were doing? Are you healed enough? So yes and no. So most patients by 5 to 6 weeks are doing 75 to 80% of their normal activities, going to church, going out to eat, doing laundry, doing some dishes, but they're not going to be out laying. They're not going to be they're not going to be outside with the weed eater or the blower. They're not going to be putting sod down in the backyard. They're not going to be, spreading hay or carrying 50-pound bales of hay or food for their horses yet. They're not going to be riding horseback, riding their mountain bike. So, and everybody's activity level is very different, right? Going into the surgery, some people are more active and their expectations are higher, and other people are less active, and that's just normal. So it's a tough question to really get a straight answer to, and that's part of the reason. Absolutely, that's why we love Matt, because a lot of patients will come for prehab and they do better because they already know what to do and they've been there. Yeah, yeah, no,
I think it's like most people in this room, everybody is different.
absolutely.
And I've got some friends that
Yeah,
had one knee done. They were just nuts. The next one was a
yeah,
nightmare.
right.
So they
Yep,
aren't the same.
sure.
It always could be different, right?
That's very true. Very true.
Something that I didn't know I signed up for. Don't know what it is.
Yeah.
I have a smart knee.
Okay.
What is that? I don't even know.
So,
I'm disgusted by.
So some of the
told what it was before they did the replacement.
yeah. So I don't personally use the knees, but some of the newer knees have some tracking devices in it, so they can record. When I say tracking, it's they can record steps, they can record force, they can record different parameters, and it depends on the knee. So I don't.
That's a little
Yeah.
bit of
Yeah.
explanation I got. That's
Sure.
okay. There's nothing
Yeah.
wrong with that.
Right, and that's sort of a little bit of a newer technology. It hasn't fully been studied or vetted, but it's interesting. Yes, sir.
Should have got a reduced deal.
Yeah, Lee, yes, sir.
Look into the future.
Sure.
Do you think at some point, 10, 15, 20 years down the road, that things, is there anything you're seeing that really,
Yeah, I think there are a lot of things out there, and I think yes, there will be some dramatic improvements. The robotic assisted surgery, I do some. I think it's promising. It's not quite there yet, but I think it's going to be an exciting time in the next. It may be more like 15 to 20 years. Other things with genetic, potential down the road, and there's so much going on, but it's really hard to know when those things will come into clinical, relevance. Things have changed a lot, and when I first started training, you had a hip or a knee replacement, you're in the hospital for a week almost. You usually needed a transfusion. You didn't go home the same day. I mean, that was unheard of. And so really the biggest changes that I've seen in my career have been, and actually it's funny, we talked about it today. I did surgery, and you'll never hear a surgeon give credit to the anesthesiologist, but I do think a lot of the improvements in expedited recovery, we have to give credit to the anesthesiologist because of the nerve blocks that they do, particularly with knee replacement. It really dramatically improves your pain post-operatively and allows you to get moving early. You don't have to sit there with a PCA or a pain pump like you did 20 years ago. So that's exciting. You look at how far we've come in the last 15, 20 years, and I'm sure it's only going to keep improving. And whether, it's going to be, more accurate surgery, probably it'll have to do with improving our precision with robotics. The data there does show some improvement in early recovery. Long-term data is not there. So yeah, I think there will be some improvement. Absolutely. Now, is it going to be a little, tiny incision or a shot that you get and fix your knee? Probably not. It's probably not going to be that earth shattering, but I think, hopefully it'll be things that'll give a more reliable, recovery, a better product for our patients.
I would say, like you said earlier, as far as I'm assuming if I used to jog, 3 to 5 miles at one point. Of course, I'm kind of half scared to do that because I wear that thing out faster. Am I not?
So I don't like my patients to jog or run after joint replacement because I do think you put it at risk potentially. Now, if you're going to play, kickball with the grandkids in the backyard and jog around the bases, I think that's no big deal. But I wouldn't go run the peach tree. things like that. Yeah, but
That's what I want to hear.
yeah. Y'all have a question in the back?
From a rehabilitation standpoint,
Yes,
do you
ma'am.
recommend home health for a few weeks, or is there a bigger push to go straight to outpatient? Is it on the patient's level?
Yeah,
What standards there?
That's a great question. So I do a little bit of both. I do typically home health for the first week or two, but I don't think it's a bad idea to start outpatient sooner. Depending on the patient and their comfort level and how easy they are getting in and out of a car. I think the earlier you get to outpatient, is the better. In-home is great because people like to have somebody there that can kind of keep an eye on their incision and make sure they're progressing properly. But I do think the sooner you get to outpatient, the quicker you're making gains, the quicker you're getting your flexibility. And so I think starting it sooner is definitely a big advantage.
My question is there anything that you see that you wish would do more of, or common mistakes that people make after surgery or something?
Yeah. So great question. So wow, the biggest thing would be getting ready for surgery by working on their mobility and their strength. The biggest thing I worry about after surgery is somebody falling down. And I'll never forget this. This was probably 8 or 10 years ago. It was Thanksgiving, and it was like the day after Thanksgiving. I was in Columbus, where I'm from, and I get a phone call, Dr. Yarbrough, I had surgery 2 weeks ago, and my granddaughter wrecked the golf cart, and well, I'm in the emergency room at Forsyth. And so that was a little more than a fall, but this patient now has just put their surgery at huge risk of infection with a wound that's anyway. So not falling, which is hard to say, but I do think preparation, working with therapy, working on balance, working on your strength, learning how to use a walker or a cane. If you're somebody that struggles a little bit with balance and gait, getting therapy ahead of time is a great tool to help lessen your risk for those catastrophic falls and events that can lead to disaster. Yeah. And your second question about after surgery, I mean, the biggest thing typically I see is people getting, feeling good too soon and overdoing it, and you usually when they overdo it, it doesn't do any long-term damage, but I worry about hips sometimes because if you do overdo it, you can end up with some instability problems that you can avoid by not overdoing it. The newer implants do give us more stability, which is great, but still it's something that I worry about. So, great question. Yes, sir.
Use staples to close the incision?
So I usually do. I usually use staples, and I don't always, but I usually do. I'm a little bit old school in that regard, but I'll knock on wood. Our infection rate is about as low as it gets, and part of the reason is we get a very good closure. We evert the skin edges, and I'll argue that our postoperative scars are less than most people in town, to be honest. So.
Where does the infection come from?
Great question. Yeah.
I'm a little nervous about that.
Sure. So two main things we worry about with infection. Number one is if you do have wound drainage after the surgery, then that can potentially create an avenue for bacteria to get from the outside world into your knee or hip, into the wound. So if there's any gapping of the incision where fluid is coming out, that's a concern. That is a potential source of infection. That's most common. Okay. The second avenue or mechanism of infection is internally. So, say you have a urinary tract infection, you have a tooth infection, you have cellulitis, and that bacteria gets into your blood. You get a bacteremia. Okay, and then that can float around in your bloodstream and land on your knee. So, this is a wonderful instrument. But as you can see, there are no blood vessels in this implant. Okay, your bone has a blood supply. Okay, your soft tissue, your muscles all has blood supply. There is no blood supply to this metal implant. All the antibiotics in the world will not defeat an infection in an implant because it will not obviously treat any metal, if that makes sense. So Luckily, I mean, the risk of infection is less than 1%. You know, we do a lot of things. We give you antibiotics before. We make you use the wipes. During surgery, I use a special irrigant that has an antibacterial solution in it. At the end of the surgery, we use that solution again. I usually help close my patients every case, so I'll make sure they get a good closure. It's a very, honestly, my closure takes me as long as my knee surgery, just about, because we're very meticulous about that. So, a lot. She knows. Yeah, yeah. I'm probably best known for that in some ways.
And then there's also after surgery dental work.
Correct. Great point.
Some people
Sure.
don't.
Yeah. So great question. It is a little bit controversial. So for 2 years after joint replacement, I recommend that you take an antibiotic, dental prophylaxis, usually amoxicillin 4 pills, and that's a 2-year recommendation. Because when they clean your teeth, bacteria from your gums and your mouth can migrate or get into you have microtrauma or tears in the gums. That bacteria can get into your bloodstream, and you get a transient bacteremia. And so that's another thing that we do. I think most people agree and do it for a couple of years, but it is controversial. I tell everybody it's a little bit of voodoo, but it's a little bit of science. And I'd always rather be on the safe side. Taking a few pills for dental procedure is not a big deal for most patients. So, correct. Yep, it's a one-time dose right before your treatment. Yes, ma'am. Yep. Yep. That's right. But
The impression that once you take those, take them as long as your life.
so it used to be a lifelong recommendation, and more lately, more people have kind of leaned towards doing it for a shorter term. But it's kind of a preference thing. I have some patients that want to do it and they do it for life. I prefer you do it for at least 2 years after your joint replacement.
What about questions we get a lot
Sure.
is okay, I don't want to have a joint replacement yet.
Correct. Yeah.
And then what about
Yeah.
the shots?
Yeah. Yeah. Great
Goodies,
question. Yeah.
Get the PRP.
Yep. Yep.
Questions.
Sure. Yeah. Yeah.
Questions.
Yeah. So great point, Matt. And like I said, probably 95% of my patients never make it to the operating room, and that's fine. And we do a ton of non-operative treatment, and it's great. And I think if you talk to most folks in town, you'll learn that I'm pretty conservative. When it comes to surgeons, I'm pretty conservative. And what I mean by that is I treat a lot of patients non-operatively and give them the option for surgery. And the reason for that is, a lot of arthritis symptoms and pain can be managed without surgery. And so how do you do that? And injections are very helpful. Cortisone injections are helpful. Hyaluronic acid gel injections are helpful. PRP injections are helpful. But they all are temporary, which is okay, but they help you to have less pain so you can be more active, okay? Anti-inflammatory medications are helpful. For certain patients, you have to be really careful because it can affect your kidneys, affect your heart. So if you have any risk factors for those problems, you may not want to take Advil or Aleve. You may just want to take Tylenol. And people tell me all the time, doctor, I just don't want to take a pill. And that's fine. I don't push pills on anyone. But every now and then you're going to have an episode where you're going to have pain and you may need a little something so that you can perform or be active. And that's when it's okay to take some Advil or take some Tylenol. But back to Matt's question, I tell everybody the same thing. My big joke in my clinic is the best medicine is vitamin E. And people look at me like, vitamin E, what's wrong with that? And you may know what vitamin E is if you've heard of. He's all over the news now. Peter Attia. Who knows who he is? Anybody? You know the book Outlive? He was on 60 Minutes like 2 weeks ago. I recorded it. If you watch 60 Minutes, I recommend you go back and watch the episode. It's 20 minutes, but Peter Attia he was a doctor, went to Stanford, super bright guy, got halfway through residency, got burned out, and now he's basically into wellness medicine. And he treats a handful of patients and has a whole operation now. It's pretty remarkable. But his book is all about how to live better and how to live better longer. Not just live longer, but have a more meaningful life where you can be active and stay active longer. And his number one finding, his number one fact that he wanted to share with everyone in that book was, can anybody guess what he said? Amen. That's right. So vitamin E is exercise. And so he is basically shown and proven that, the more you exercise, the more muscle mass you're going to have, the better your bones are going to be, and the longer you're going to have a quality life, a good quality of life. And so with arthritis and a lot of the ailments we see, it's the exact same thing. And that's why we love Matt, because people come here and they realize that I can do this, and you feel better and your joints feel better. And so that's what we love to see, and it's something that you can do yourself. You don't have to have a machine or join a gym. Even just walking, riding a bike, I mean, there are tons of things you can do to get exercise. Everybody asks me, what's the best exercise? Dr. Yarbrough, what is the best exercise for me to do? And there's the answer is simple, and it's the exercise that you do. Whether you're swimming, whether you're doing yoga, you're doing chair yoga, you're doing Pilates, you're riding a bike, you're doing a treadmill, you ride a unicycle. I don't care what you do, just don't wreck. But in all seriousness, the best exercise is the one that you do, and that's probably different for you and you and you, and for me, and the other thing, I wanted to hit on this earlier, I forgot, but the other thing is that when I send patients to physical therapy, I mean, Matt and Jill and Eric, all these guys are awesome, but inevitably people will go to therapy and a lot of them will come back and see me and say, I did it for 2 weeks and it didn't help me and it hurt. And I said, well, you went for 2 weeks, you did 2 or 3 visits, maybe 4 visits, and that is not enough, and so it's normal for physical therapy or exercise to be uncomfortable. It's not going to feel good at first, and I really try to hammer that home, and it's hard for some patients. But when you talk about grit, I mean, it really matters when it comes to therapy and fitness, and it's different for everybody. But that's a big piece of it is staying active and exercising. So.
I think I'd like to add to that. My experience with that first 2 weeks is miserable. So I find that usually it takes about 6 weeks. That's how long it really takes to increase my physiological changes in the body. I've noticed that with my own workouts too. Like plugging through these workouts for 6 weeks, miserable, but then something kind of clicks all of a sudden, and then you start to enjoy the workout. It feels really good. So if you start to get discouraged at the beginning, just push through it a little bit longer, shoot for that 6 week mark.
That's a great point. I agree. I think that's a great point. And some people it might be 6 weeks. Some people it might be 3 or 4 weeks. But great point. Thank you, Joe.
Okay, so I've been a patient years.
In a long time, yes, sir. God bless you.
I'm here. Yeah. Prior to that, the shots, they're complaining about it. Okay. I was shocked. I've gone through all of it.
Right.
And then last episode was the supines.
That's right.
Three. I said, come back in 6 months. This probably go up. Let's go 5 and 5 months.
Right.
In your office every year.
Right.
You were out and how could you get this? And you were nice and long, and if the file frees out or whatever that is,
Right. Yep.
numb it up, and then that's it. And I'm ready to go for another year.
Right.
And when I rolled my hip, I knew that Matt was an acupuncture. That's people are scared about that. The shot. Come on. You want to get cut on, or you want to do some
And you're still moving, Joe.
That's right.
You're still you're getting her done. You're getting this. You're getting your
Yeah.
injections. You're getting
Yeah.
your medicine.
Right.
You're doing what? You're doing your
Yeah.
karate thing now, right?
Yeah. I love
Your
it.
boxing,
Yeah.
MMA. You're
Sure.
rolling around there and
Oh,
wrestling
that's
around,
amazing. That's amazing.
right?
Yeah. You know, I mean, you bring a great point, John. I'm glad you mentioned that. I mean, everybody comes to me and they're like, well, I don't want surgery, and that's okay. And then we offer other things, you know, physical therapy, injections, and, you know, then there are a lot of supplements out there now. The peptides, I'm sure you guys have read about the peptides and the collagenase and the collagen. And there's some okay studies that do show some relief and some promise, but it's temporary, you know, just like injections are temporary. Just like, physical therapy. Physical therapy is not temporary if you do it right and you keep doing it. But the bottom line is everything is somewhat temporary. We're trying to do maintenance and make the best of your body, and that requires, unfortunately, ongoing treatment. And so, however, some people may get an injection and do well for years and years, and that's great. Yeah, that's a good point. I appreciate that.
Do we have any other questions? So, you know, he hit on it. The big push in the medical community these days is quality versus quantity, really, of life. So when you hear people at the end stages of life, they're not going to try to keep them on a ventilator for the last 10 years of their life because it's not quality. But if you can get quality with a little bit more quantity, then it's a great life.
Absolutely.
And that's what we're kind of preaching here today. And you guys, thanks for coming because, like I said, a lot of you already had some of these surgeries, and it's great that you're here to ask questions. But we want you guys to be a sounding board to your neighbors, your friends, your family, because a knee or a hip that's preventing somebody from enjoying life is not okay, and there's no sense in putting that off. And that's when you make the call to Doc. Or you call me and I get them in with Vicky, and Vicky gets them in with Doc. Bless her heart.
Thanks, Vicki.
Yeah, Vicky, thank you very much. But it's not okay to stop living life. And life expectancy is so much more than it used to be. But that quality sometimes is not there. And that's what we need to promote that.
We have a knee replacement. It works very well. You have problems on steps. Is there a common cause as far as stairs?
Sure. So let me ask you this, is your problem more going upstairs or downstairs?
No.
Is it pain or weakness or both?
Listen, maybe a little bit of weakness.
Sure.
Sometimes I have to reassure myself that it's not going to bother.
Yeah, I will tell you that the hardest thing for your knee to do is to go down a step. And the reason, Matt knows better than I do, the joint reaction forces on your knee, in particular your patellofemoral joint, are 4 times your body weight. So that is a ton of stress. And basically, when you're going down a step, it's a controlled fall. And the only thing stopping you from falling is that quadriceps. And so that's good.
Let's keep it that way.
So, it's not unusual that you may have some quadriceps atrophy or weakness that can cause that. Sometimes there can be some inflammation or irritation in the patellofemoral joint. Even with the knee replacement, that's not, horribly uncommon. Usually it's not a severe pain, but it can be, some at times. But, that's a good question. I would say look at your quadriceps and probably working on quad strengthening would be the first place I would start. And obviously getting x-rays of your knee to make sure, it would be very unusual, but to make sure there's nothing, loose or out of alignment.
Yeah, it's usually the deceleration part of any of that knee component. So downstairs is a common. You're not alone in that. That's a very common complaint, and that's why we work a lot on anybody that's been here before. They're on the leg press. They're hearing us preach. You're pushing up with both. You're letting down with one. We're working on deceleration moments in the knee. We're working on eccentric contractions because that's what's going to help that. in the long run. And it's just, and some of it's confidence, and it'll just come in time too as you get stronger. But the strength, flexibility, balance are all key aspects of that quality of life. So,
Good point.
hopefully anybody else got any other questions? Oh, here we go.
I'm coming up on a year on a knee replacement, and the only problem I have is that clicking. Upstairs, downstairs, I never had a problem at all, ever. Also, I was put on an app. I'm not big on apps, but the app couldn't tell me when I wasn't doing that thing right. This is me personally. And I didn't start really healing and coming back when I came to see him at this place. Yeah, I'm a good cheerleader for this place. So is my wife.
I'll pay you later. Don't worry, I got you.
Yeah.
I got you.
But again, it was caring that I was here and showed me what I thought I knew wasn't right, how to do it correctly.
Right.
And to me, that's been a whole difference. Oh, if the clicking never goes away, okay, it doesn't. But I'm gonna try my best to get rid of it if I can.
You just want to be able to sneak up on people, and you can't do that right now. That's okay. It's your wife probably told him to do that to you.
She's got the app and she's tracking. So.
Everywhere you go.
That's funny.
Usually with strength becomes stability with that.
Yeah.
And it's, it doesn't, and I tell people this all the time, you didn't get a bad knee overnight. And atrophy, walking pattern, I mean, I'm already bow-legged now, so when I get my new knee coming up here, hopefully I can put it off as I get my 60s. It's going to be a lot of change for me, and I'm going to have some click in it, but I'm trying to keep my knee as strong as possible. I live in this world. I'm doing pretty good right now, but that does get better. But there's sometimes it doesn't. Like he said, these are components that are plastic on metal, and they make noises.
No one even gonna say this, but I wanted to say it. As far as the jogging, those are great times. Different phase of my life, but still.
Speed walk.
Yeah.
Yeah, just fast walk. Yeah.
Treadmill.
That's right.
Bicycle.
I got one of those at home, one down here at the gym.
What?
Only thing coming back here is screwing up with going to the gym. Well, when I go down there, I'm working from here up, and I'm with you, I'm working from here down.
And then
That
also
works out.
friends and neighbors and family too, that I would tell you that we were talking about the exercise component of it. Even if they walk to their mailbox and back, and they don't normally do that, that's something they don't normally do. And then walking, I have a neighbor up the street, I see him walking, doing from his mailbox like 14 or 15 times a day. I mean, back and forth, back and forth, back and forth. I'm like, good for him. But you know what? Next week, he's probably going to be up to 20 and then 25. And he's at least doing something than nothing. And I think that's the part that's very bad for people, is choosing to do nothing and not doing something.
You gotta make that choice.
Yep. And like, if you just can't do it, then you got to do something. And that's where you start with getting in. Let's see Doc, and let's get the ball rolling with him to see if he can get you going on something. And that's really why we're here today, is to let your friends and neighbors know, let your family know that if they're in this situation, let's spread the word. Let's live a healthier lifestyle. So.
Well, I think all of us here have learned a lot that we didn't really realize was out there. We thought we knew it. You helped us with that.
And if you guys want, come up here and look at some of these little components, because they're pretty
to,
interesting how they look.
Or not.
And also, this is pretty cool about this. I think this is the most. In fact, I don't know how much longer he's going to be doing what he does.
Oh,
His
yeah, I don't
son
know,
is
yeah.
a race car driver,
Yeah.
and I'm trying to get on the pit crew. I'm trying. I don't know. I'm not real fast. So yeah,
we're going to have you ready. You're
you
going to
can
be
come
good.
up here and get some of these and follow
Ah,
this kid.
that's
This
funny.
kid's going to be like. I'm thinking we're going to go
I
NASCAR.
mean,
I'm going to go see a race.
Let's go.
yeah.
We'll see about that. But
come up and play around with some of this stuff. If you want to ask other questions of Doc, we're gonna kind of shut it down now and stop the filming, and y'all can chew potato chips and stuff then. But thanks for coming.
Thank you.
Hey Doc.
Yeah.
Hey.
Thank you.
Thank you,
Thank you, man.
Yeah,
I love it.
absolutely.
That was fun.